You're watching The Wellness Hour, the leader in medical news and information. I'm Randy Alvarez. Today's topic, what you need to know if you're considering any type of breast surgery. With us, we have the go-to guy in Santa Barbara, Los Angeles, in fact, all over the world, expert on breast surgery. He's written medical text, over 60 published articles on this topic, Dr. Neal Handel. Dr. Handel, welcome to the program.
Thank you. It's a pleasure to be here.
Now, by the way, because I've talked to like Dr. Greg Keller, other surgeons since we've talked on the phone, I mean, I think just about every plastic surgeon, especially those that do breasts, they know who you are.
Well, I think that's true. I am well known, and I'm grateful for the recognition that I've received over the years.
I was told you're the best in the world.
Well, it's, you know what, it's...
So Greg, Dr. Keller actually said that about you.
Well, I don't want to dispute him.
Said
He's
I
an
was
honest
lucky
guy.
because you're lucky to get this guy in your show. That's what he said.
Well, I appreciate that, and Greg is an honest man, so I'm not going to dispute what he says. No, I'm not.
Is there that much to it? And I say that respectfully. And I know in the lifting, and I've read your bio, so it's, you know, I have a lot of questions. But with just a regular augmentation, is there that much technique? And do you think the public, the lay public, me included, thinks that you guys are all kind of doing it the same way?
Well,
there's not a lot of art to it?
I think that there's a certain unsophisticated viewpoint where people feel that's a pretty simple operation. And, you know, from the standpoint of what we actually do, creating a pocket or a space under the breast and inserting a bag with water in it or silicone in it, sure, conceptually it is simple. But if you want to get the best results, there's a lot that goes to the finesse of how the operation is done, selecting the correct technique, the right operative incision, the right implant to meet the patient's anatomical needs and her cosmetic expectations.
So is it true? I mean, most women sometimes will just, you know, price shop, just like whoever's the lowest?
Well, there's no doubt that people price shop, and I think that that's probably a mistake most of the time because what you really want is the most experienced surgeon, somebody who's done this thousands of times, been doing it for decades, and has excellent judgment. I mean, there's no substitute for judgment. And
but the results, I mean, how they look. I mean, you show your patients, you know, other patients that you've done. Is that correct?
Absolutely.
I mean, we can't show them on our show today.
No, and that's unfortunate. I understand that, but absolutely,
because you wanted to, and I said we can't.
I'd love to, because you know what, plastic surgery is really a visual specialty. I mean, you know, we could talk about it day and night, but when you see before and after pictures, that really is what makes the difference. I mean, that's jaw-dropping.
And women travel to get their breasts done with you.
They do.
Is that right?
I did somebody 2 days ago who came all the way from Saudi Arabia, and she's a nurse.
Is that right?
That's right.
So what's new? I mean, what's new in the last 10 years,
You know what?
15 years?
There have been some incredible advances, not in the last 10 or 15 years, but in the last 10 or 15 weeks, literally. There are new implants that have just been approved for use in the United States by the Food and Drug Administration. Happen to have a couple of examples here of the implants that are now available. And this is going to radically change what we can do for women in terms of...
So better, more natural looking breasts?
Absolutely. We have a much wider array of tools now available to us to achieve a patient's cosmetic goals.
So as of this taping, they came out like a month ago? A couple of months ago?
These implants literally, some of them have just been approved by the FDA and aren't even yet being distributed to plastic surgeons.
Let's talk about those. Let's take a look.
All right, well,
what'd you bring me?
All right, well, let me ask you something.
Okay.
What do you think the difference is between these three implants?
They just look like, I guess, some different sizes.
Guess what? You're absolutely wrong.
I'm wrong. Okay.
They're exactly the same size. Every one of these is a 275 cc implant. And I'm glad you said they look like different sizes.
I said the right answer. Okay.
You did give the right answer. What these are they're all the same size, the same volume implant, but in different profiles. This is what's called the moderate profile implant.
When you're talking about profile, what? How they,
height.
The projection?
Exactly, projection and base diameter. This is something that's relatively new. It's something that plastic surgeons really need to think about and educate their patients about. And not everybody does that. You know, a lot of plastic surgeons still go, you know, what size do you want? Stick an implant in the patient's
doesn't
bra.
really go on, because I know you lecture. Look, you're at UCLA.
Yes,
you
I'm an associate clinical professor.
Yeah.
Yes.
So those three, and I interrupted you, but those three.
These are all the same sized implant, but the difference is the profile. This is what's called the moderate profile implant, the moderate plus, and the high profile implant. So basically, as we go to a higher profile, the implant has a narrower base diameter.
But doesn't everybody want a higher profile?
No, I'll tell you what, it can make a huge difference. We need to individualize the shape of the implant to match the patient's anatomy, for example.
Okay.
A woman who's got a very wide chest and wants a certain volume implant, let's say a modest breast augmentation, If we put a high profile implant in her, she's going to have a round mound in the center of her breast and not going to have good cleavage or adequate lateral fullness of the breast. So in that
But doesn't
kind of a
every
patient,
surgeon know that, though? I mean, because logically it sounds like
logically it does sound that way. Believe me, different profile implants have only been on the market for
So you
about
think
the last
mistakes
10
are being
years.
made then in the
Absolutely.
Okay, good,
absolutely.
good.
We need
so
we
cleavage, all of those things are in the diagnosis to do the right judgment of you,
correct.
the surgeon. Okay.
I don't want to interrupt you, but look, in evaluating a patient, we need to take a lot of factors into account, not just that I want bigger breasts. We need to look at the patient's anatomy. A lot of women have asymmetry of the chest wall and aren't even aware of it until I point it out to them. You would be amazed the number of times I'll stand a patient in front of the mirror and say, do you notice that your left breast is a little bit lower than your right breast? And they'll go, oh my gosh, I've never noticed that, but you're right. You know, here's somebody who's looked at themselves dozens of times a day in the mirror for 25 or 30 years and only now realizes that there's that asymmetry.
Okay, so knowing that, how does that make a difference in your treatment?
Well, here's how it makes a difference. We want to point these things out to patients so that we can pick the operative approach, the style and size implant, and do the surgery technically in a way that's going to help them achieve the best possible cosmetic
When you say
result.
operative approach, you're talking about whether you're going to place the incision under the fold?
I mean,
or the...
You alluded or mentioned a few minutes ago, you know, isn't a breast augmentation a pretty straightforward operation? Well, conceptually it is. It's, you know, make an incision, create a pocket, stick a breast implant in there.
Knowing what you know, when you hear that from a guy like me, do you think, boy, this guy doesn't get it?
Well,
where do I begin with this guy?
I'm just wondering where you did your plastic surgery residency and how you finished it.
Well, I'm glad you didn't lose your cool over that question. Okay.
But, you know, I started to talk about the fact that when we see a new breast enlargement candidate, we need first and foremost, of course, to assess her anatomy because every woman's different. In addition to that, we need to determine what her goals are because what
like example, like what?
Well,
give me an example.
let me give you an example because I'll often say to patients, you know, we're trying to achieve a natural looking breast, something that, you know, is very attractive and looks like it is unoperated on. And I'll have patients say to me, no, that's not what I want. I want to look like I've got a boob job. That's her aesthetic. I accept that. I understand that. I can live with that. I'm comfortable with that. So we really need to individualize it to what the patient's trying to achieve. Okay. We also need to take into account things like the thickness of the patient's tissues. That's very important. The laxity or elasticity of the patient's tissues.
By the way, when you say, just so I understand where you're going with this, when you say you have to take these things into consideration before you choose the implant that's going to give them that result?
Before we choose the operative incision, the placement of the implant, whether it's going to be above or below the pectoral muscle.
And there's not enough of that going on by any chance?
I think that there's more to this than meets the eye. You know, that you really want to find a surgeon who gives this operation the attention that it deserves in terms of attention to detail.
So you're matching it up to their expectations.
Absolutely. And that's really the great thing about having a wide variety of implants available.
So the high projection, who's that best for?
High projection implants are excellent in patients who have a narrower chest diameter, who want maybe a more glamorous look, who want to have more upper pole fullness.
That means they already have a lot of cleavage, or no?
They may or may not have a lot of cleavage. That part's really not so relevant.
What do you mean the chest dynamic?
The base width of the chest. In fact, let me show you something. What we do now, in the olden days, and when I'm saying the olden days, we're talking just a couple of years ago, we would throw different sized implants in somebody's, you know, in a bra that we gave the patients.
That's what I hear on my show sometimes.
Yeah, that's really not a scientific or very good way to do it. It's not an accurate way to do it. What we do now is we actually
this is interesting.
We actually analyze the patient's anatomy in a very scientific way. We use a device like this to measure the base width of the breast that we're trying to achieve. We use a caliper to actually measure the thickness of the patient's tissues so that it can help us to better assess whether to put the implant above or below the muscle. We check the elasticity, the stretchability of the tissues. That can help us to not only choose the correct size and profile implant, but it may also lead us to decide to use the latest and greatest and newest thing on the markets, shaped or anatomical implants. Now this is something that you haven't seen on your show because these were just approved for use in the United States by the FDA within the last several months. In fact, 2 of the manufacturers haven't even started distributing yet to plastic surgeons.
So you're one of the first guys?
Absolutely. I'm going to San Francisco next week to give a lecture to plastic surgeons on how to use these new implants called
Do they have a
memory-shaped
name, by the way, a
implants.
slang name that the public will be using?
Anatomical implant, shaped implant. These
But
implants,
I've heard anatomical years ago.
well, anatomical implants were available in Europe for the last 10 or 15 years, but they were not available in the United States. We need to take the patient's anatomical characteristics
yeah.
into account. I mean, every woman's not the same, and we need to take a woman's aesthetic desires and wishes into account.
So when I hear on this show, my program, airs all over the U.S. and Canada. I've had plastic surgeons say, Randy, the most accurate program is, and I don't know any better. Obviously, this is all I know. I'm hoping you guys are telling me that this is, but they try on a shirt and a bra, and that's how they choose size. And you don't like that at all, is that?
No, we do that in addition to these other modalities.
What percent are you? But all surgeons aren't doing that, measuring it the
I
way
would
you're
say
doing
that all
it?
surgeons are not doing that. No, even though most plastic surgeons are aware of these techniques,
They don't see the benefit in doing it.
it requires more time, a lot more time.
A lot of measurements.
Absolutely.
Okay.
You really got to, unfortunately, some of my colleagues are specializing in doing the largest volume of cases in the shortest amount of time and reducing the length of the consultation. I'm going to tell you that it's typical in my practice for the consultation to take longer than the operation. We spend
Is
more
that
time,
right?
absolutely. We spend more time talking about it to make sure that the patient understands what to expect, to make sure that I understand what she wants, and to avoid disappointments later on. So, often I'll spend an hour and a half, 2 hours talking about a breast augmentation with a patient, do the procedure in an hour.
People need to know it's a real interview. I'm not necessarily endorsing you, but people say, who should I go to? And I say, go. I go, it doesn't cost more to go to an expert. I mean, if you're a world-renowned expert, the plastic surgeons that I talk to over at UCLA say, like Gregory Keller says, this is the best breast guy in the world. All the doctors are sending their wives to Dr. Handel, Dr. Neal Handel. And you're measuring and you're a perfectionist and you've got just about more before and afters than anybody. You lecture, you teach other doctors how to do this. You've written a medical textbook teaching doctors how to do this, right?
Correct.
And you do more breast surgery sometimes maybe in a month than most guys do in a career.
Absolutely.
Okay.
Absolutely.
So, and we talked about this. I said, what about prices? And you're about the same when you compare apples to apples as everybody else.
I believe that we've kept our fees very, very reasonable.
Okay.
We made an effort to make this affordable
I had to throw that
people.
in for you. A little bit of a plug there.
Thank you.
But because rarely do I get impressed with the people on the show. But you're one of those guys. I was excited when I posted it on Facebook. I've got you coming in today. But anyway, okay. So you were saying, picking the right implant, the right diagnosis. I'm calling it a diagnosis.
I think that's an accurate way to put it. Diagnosis is exactly what we have to do. That's the first step, and it depends, again, on the patient's anatomy, on her goals, on her aesthetic. Not everybody's got the same aesthetic. And I often ask patients, not only do I show them my before and after pictures, I ask them to bring in photographs of what they're looking to achieve. That's really very helpful.
Is that common? Because they could pick their breast based on what they like?
Well, it can certainly help us to understand the size that they want. What I'll often do is tell the patients, on the day of your surgery, I want you to bring some tear sheets in from magazines. It could be from Playboy, from Penthouse, from Cosmo, from Glamour magazine. Clothed, unclothed, whatever. We put those pictures up on the wall in the operating room so that we actually know what the size, what the contour, what the shape that the patient is looking to achieve. The nurses and the surgical techs are extremely helpful in this because, sometimes we'll try different profile implants. We'll try different shaped implants. We'll try different sized implants because we could put in temporarily what we call sizers during surgery, sit the patient up, compare what she looks like to the photographs, and often we can very, very closely simulate the exact look that she's trying to achieve.
Going back to those implants, we got sidetracked. What can you do now with those implants you couldn't do with the traditional gel-filled implants?
You know what? The shaped implant, I think, gives us the option to create a much more natural-looking breast. If you look at this implant in profile, you can see that the upper pole slopes, that there's more projection of the lower portion of the breast. And what that helps us to do is...
And it keeps the shape in the body.
For patients who want a more natural-looking breast.
So it gives that kind of small at the top and at the bottom.
Correct. The kind of teardrop shape that is often considered, not by everybody, but by many patients.
This is like 8 weeks old, you're saying? As far as here in the U.S.?
Correct.
Wow.
One of the manufacturers got them approved about a year ago. There's 3 manufacturers in the United States. The other 2 just got them approved and are just launching them right now.
Now the redo crowd, the women that have 15 years in, 20 years, is this like a great option?
Well, it is, but I also wanted to mention that this there are some plastic surgeons who will say, you know what, it doesn't make any difference. You can't tell once it's in the patient.
I've been told that, by the way.
Yeah. Well,
They say, Randy, it's under the tissue, under the muscle. It's not going to show.
That's a very,
it's a
very
gimmick, they said.
It's not a gimmick. That is a very naive and simplistic viewpoint.
Do you believe they don't get it, or they're just not telling me the truth?
They may not get it, unfortunately. And it does vary from patient to patient.
Okay.
Let me give you an example. Somebody comes in who's got a very adequate amount of her own native breast tissue, B cup, full B cup breast. It probably isn't going to make a big difference in a patient like that. But in the patient who's got a very sparse amount of breast tissue, who has an A cup, no breast tissue.
So very little breast tissue.
Very little breast tissue, or a tighter skin envelope, doesn't have the elasticity
lean,
or laxity.
very lean person.
Lean patients, patients who maybe haven't had any children. In those patients, the shaped implant can make an enormous difference.
Because on the leaner patients, I've noticed when they show me,
they
it's
look
like a
fake.
round breast.
Right.
So
Looks
now
like a half a cantaloupe.
So now it's actually going to look like a breast.
It will.
Like gravity is.
That's correct. And in a patient who's got a very thick, that's why we need to do the pinch test to analyze the thickness of the tissue. In a patient who's got a very thick, supple, soft tissue envelope, it probably isn't going to make as big a difference. And those patients I would tend to direct towards the round implant. So we still are going to use round implants, maybe even in the majority of cases, but we've got more tools now in our tool bag. We can do a better job. So
the results you're getting today are so much better than 1,000 breasts ago.
Absolutely. There have been a lot of innovations, not only in the technology of breast implants, but even in our own surgical techniques.
And your hunch is, by the way, that still plastic surgeons may be resistant just because they're used to the old style.
There's no doubt about that. People get into a groove, they get into a habit of doing something a certain way.
And those might be a little bit more.
Cost-wise, these are more.
So like 1,000 more?
Less than 1,000, but $600-800 difference.
It's worth it because their breasts are going to last 15, 20 years.
You know what?
Or more?
It's absolutely worth it if the result is going to be better, if the risk of a suboptimal outcome is lower, if the risk of a complication or a reoperation is lower. It's absolutely worth the upfront investment. It just makes good economic sense.
Is the other one the same thing?
Is
that just a smaller version of that?
No, actually it's not. This isn't. The reason I brought this is to show you that not only are there differences in the profile, remember this is the shaped implant, this is the unshaped implant. So the shaped implant projects more. There's also differences in the footprint of the implant. This one's round and this one is an oval. Do you see the difference there?
Yeah.
You see that? Mm-hmm. We need to take that into account too. There's a whole bunch of parameters or variables that we now look at. We could look at the height of the implant that we want to choose, the base diameter or width, the degree of projection. Do we want it to be low, moderate, or high in projection? And the shape. So we have a whole variety of different parameters, choices now, that we really need to think about and apply to the specific patient to get the best possible result for her.
Actually, I wanted to ask you this. I'm glad I didn't forget to ask you this. Because I've had surgeons say that if you have unattractive small breasts, you get an augmentation, you're going to have unattractive large breasts.
That's probably true if the plastic surgeon doesn't give the appropriate attention to detail, because
So it doesn't have to be that way?
Absolutely not. Because there may be things other than just making an incision and throwing in an implant. If that's all you do, you probably aren't going to get the desired goal. But if you take into consideration the shape of the implant, maybe design an operation that includes some type of an uplift, an operation that takes into consideration the diameter of the nipple and areola to reduce it to something that's aesthetically attractive. These are all factors that need to be weighed into making the final decision about the appropriate approach in that patient. That's where shaped implants come in, different profile implants, different base widths, different projections. All of these things are important to individualize the operation to meet that patient's needs and desires.
If there's a mistake the doctors are making with the so-called simple augmentation across the country, what is it in your view?
There's a whole host of things that can be done wrong, but certainly not properly matching the breast implant that's selected to the patient's anatomy. That's a big mistake that's commonly made. And you just don't end up with as pretty a breast as you could. You end up with what I would consider a suboptimal result. Yeah, the patient came in for a breast enlargement, she's got a bigger breast, so the operation was successful in that regard. But is it as pretty as it can be? Is it feminine? Is it attractive? Does it match the aesthetics that go with that particular woman? Does it make her feel good about herself when she's wearing that small black dress, when she's on the beach in a bikini? That's really our goal. I mean, you know what? This operation isn't so much about breasts as it's about self-esteem, self-confidence, feeling like a woman. That's really what the operation's about. It's funny. It's an operation that we're doing on the breast, but this is the part of the body that we're trying to affect the most.
Tell me this: are the patients getting older and older, younger and younger?
You know what?
Mixture of both.
We see patients, an entire spectrum of patients, ranging from young women in their 20s who've never had much in the way of breast tissue and have always felt deficient and inadequate in that way and not had much confidence, to older women who finally say, you know what, I've raised my kids. Breast augmentations up to age about 60. It's unusual to see patients over the age of 60.
Now, you brought a photo.
Well, you know what?
I
know that in plastic surgery, it's so critical that we could show people before and afters, and I know we have some limitations in what we can really show on television. But this was a patient who actually just came to my office this week. I saw her 2 or 3 days ago. She actually lives out of state now, but she's been my patient for 20 years. She came in for some Botox and for some Juvederm to little fillers on her face. But she's a gal that I did a breast augmentation on 20 years ago. And I said, Pam, I'm going to be doing this show with Randy next week. Do you mind if I use some pictures of you? Because you've had a great result. It's lasted for 20 years. And she said, absolutely, use my picture. So these are some photographs just of her sitting in my office. She's obviously a beautiful woman in her mid-40s.
Yeah, she looks young.
Doesn't she? She looks great. I mean, she's very, very pretty, always has been. And these are what her breasts look like about 20 years after a breast augmentation. Now, I did her surgery through what's called the axillary or armpit approach. So I asked her to hold her arms up and proudly show off her scars. So these are scars that have had a long time to heal, so that they've faded a lot and they're not too noticeable.
Okay.
I also said, hey, Pam, can you lean forward and show some cleavage? So,
well, tell me this, but why go through the armpit? I've had guys come on my show, plastic surgeons, that say, Randy, the problem with that area is, sometimes the patient is dictating the surgery. I don't want any scars to show, so go through there, and the surgeon just says, okay. He says, but it's not a good way to go because you can't place the implant in the right place or something like that.
Well,
so
what you're bringing up, I think, is very important and has really been one of my pet peeves for years, and that is that there are some plastic surgeons, and there are excellent plastic surgeons, but they get into a routine and they do the operation the same exact way every time.
So what I've heard on my show is typical. I mean, it's a lot of guys.
It's not uncommon.
Like, don't do the armpit.
Every breast augmentation I do is through an incision in the crease beneath the breast. I always use saline implants. I always put them under the pectoral muscle.
Why not in the fold of the breast? Because some people say don't touch the. They've told me this. It's a good argument.
It is a good argument. But this is a patient that I did 20 years ago. She'd never had any children. She didn't have a breast fold. She had a breast that didn't have a crease beneath it. That is not a patient that you would make the incision in the crease of the breast. There is no crease. It means the scar is going to be right on the front of the breast and very obvious.
Does that happen even today?
Even today, for somebody who's...
But what if the doctor says, well, gravity will relax it, bring them down in a few years? You're laughing at these things.
I am, because the way things are going to change over time is a little unpredictable. I mean, really, nobody knows exactly how much one woman's breast is going to stretch and sag with pregnancy. Nobody knows whether or not a patient's going to get stretch marks on her abdomen after a pregnancy. You can't always predict. And I think what you really need to do do this the right way, the intelligent way, the smart way, is to analyze the patient, to analyze her anatomy, and to do what's best for her. Now, you know what? In the final analysis, I'm going to do what the patient wants. If the patient says, I understand all that, Dr. Handel.
Yeah, like absolutely not.
They said, you know what, I want a saline implant. I might say, you know what, I think a silicone implant would be a little bit better for you. I want a saline implant. Absolutely, I'll do a saline implant. You want the incision under the crease of the breast? Yeah, let me explain to you what the advantages and disadvantages are. And if that's what you want, that's what I'll do.
Well, let me ask you the preference.
No, I'm sorry.
You have the fold. You have the fold. You have the nipple area, and you have and then the belly button.
There's even the belly button.
Right? Is that right?
Well, that's correct. There's only about 1 in 100 plastic surgeons in the United States, about 1% do the transumbilical approach. I do it because I know how to do it. You know that old saying, if a hammer is the only tool that you have in your toolbox, then every job you're going to use a hammer. If surgeons don't do the transaxillary approach, the armpit approach, if they don't do the transumbilical or tuba approach, they can't offer it to patients. So what they'll tend to do is badmouth it. They'll say, oh, can't position the implant correctly that way. Can't get the desired cleavage. It's not a good operation. It's not a good operation in their hands because they don't know how to do it.
Okay, by the way, if you're just tuning in, because if they just tune in right about now, they need to know who I'm talking to. Dr. Neal Handel, and by the way, you have written medical textbooks in medical schools. You lecture to plastic surgeons.
Audiences of plastic surgeons
across
around
the
world,
country,
around the world,
teaching them how to do the right breast implant. What I'm picking up on, though, there's more than goes into this, a breast aug than meets the eye.
Absolutely, I think that.
And the public thinks that everybody's doing them the same way. And going into this, I really kind of was thinking, I mean, how could there be that?
Well, I realize that, and that is, and pardon me for saying this, kind of a naive viewpoint. I mean, that's oversimplifying it.
Okay.
To do it right requires finesse, requires technique, requires style, requires really understanding not only a woman's anatomy and physiology, but also knowing the whole array of options that are currently available, and determining, and I think this is very important, determining what that woman's aesthetic is. What does she consider a pretty breast? Because not everybody has the same taste. Not everybody has the same goal. We need to really tailor the operation to give us the best possible chance of meeting that patient's expectations. That's what we want, a happy patient, someone who's confident about their appearance, who feels comfortable in a variety of different types of clothing, who feels comfortable and dressed in front of her lover, her husband, her girlfriends, at the gym, at the health club. Those are our goals. And we can only achieve that by really understanding what the patient wants and understanding the wide variety of tools and techniques available to us.
Could you tell them, by the way, from looking and doing enough of these, where you say, this is going to be a great result?
Yeah.
With certainty, could you say, oh boy, this is going to be good?
Well, based on having done this for a number of decades now and having done literally thousands of these cases, I've seen just about every permutation and combination you can imagine. So I have a very good idea when I see a new patient about what will give the best aesthetic result.
And you see that end result?
I do. And I certainly have my preference in what I would recommend to that patient. And they'll often say, hey, what should I do? What would you recommend? And I'll tell them what I recommend. But at the same time, in all candor, I've got to say, you know what? It's your body. You tell me what to do. I'm not going to tell you what to do. You tell me what to do. Because some women don't have a tolerance for scars.
Well, thank you for coming to the show. Very interesting, by the way.
Thank you for having me.
And,
it's been a pleasure.
So they can look at these photos on your website, drhandel.com.
Correct.
And you're new to Santa Barbara.
Well, I've been practicing on and off at Santa Barbara.
But now you're going
to be there full
living
time.
there.
I'm making a full-time commitment to my patients in Santa Barbara and in that region.
Well, good for you. Good for you. I want to thank you again for coming on the show.
Thank you.
You've been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again, if you just caught the last 5 minutes or 10 minutes, go to wellnesshour.com. Just put in Dr. Handel. You'll find him there. For now, I wish you good health.
Thanks for watching The Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.